The next speaker now, Dr. Senthil Thambidurai from the United States. I will take a few minutes to introduce him to you all. He's a wonderful guy, wonderful friend of me. He has had a very successful career, and I wish him all the best in his future as well. And he is one of the persons to look for in the coming days. Uh, he has made a lot of name for himself in the United States, and we are sure to hear a lot about him in the coming days. So, Dr. Sindel will speak about his journey here. Uh, I see Dibs joining us. Hi, Dibs from London. It's morning 2 a.m. for you, mate. Thank you for joining us. Sorry about the timings. I had to choose a time
No
where I have
problem.
to
All right.
accommodate, yeah, Indian audience as well as the US. So Dibs, so I've completed my part of the presentation. We are moving to Dr. Senthil Thambidurai's. The whole webinar is recorded. We have had 50 to 60 registrations so far, but very few of them have turned up. It's Sunday morning, and it is Generation Z we are dealing with. So we should let them have their time. And this webinar is recorded for them, and they can come back, and I will be sharing the link to all the registered people so that they can go through the webinar whenever at their leisure. So I'll still share my screen. Allow me to share my screen, Kirti, so that I introduce Dr. Sendil. Yes. So Dr. Sendil, he's the program director of electrophysiology, Medical City Fort Worth, USA. Uh, he's a regional director at the HCA, North Texas, USA. I will allow time for Sendil to speak more about his journey here. If you're on LinkedIn, you will follow him, a very active guy. A lot of things spoken about him, written about him, posted about him from his fellows. What more, I mean, credit or tribute you would get rather than a fellow posting a post or uploading a post on social media, thanking his mentor, her mentor, telling what all she has or he has done over the last few days or her experience as a fellow with him. So he's a great guy to work with. He has started recently his fellowship program this year. This is my experience with him in the latest Asia Pacific conference. So he has an accredited electrophysiology fellowship program that was started July in 2024. Already I am hearing great words about him and good things from his fellows directly. I've had a couple of interactions with them. This is one for all of you to see. This is one of his fellows directly posting, thanking him about the opportunity provided to her in his own lab. It makes sense to understand what was his journey right from India. I started here from the Cleveland Clinic, but I will ask or request Dr. Senthil Thambidurai to take his journey right from India. Then how did he land up in the Cleveland Clinic, and how did his move up the ladder slowly into the Texas cardiac arrhythmia, and for the wonderful program that is running as a regional director electrophysiology there. So how did he reach there? What we would like to understand, the Indian electrophysiologists and the fellows, is your journey, how good electrophysiology is a career. As I mentioned with you in private, that electrophysiology career as an option in India has to be propagated. We as an electrophysiologist, India and abroad, we need to reach out to our younger generation, telling how good the career is and what are the opportunities are there abroad. We are competing vis-a-vis with the structural guys here in the country. So there is a false notion that electrophysiology is not a good career, but this webinar is exactly to put that word across that this is a fantastic career. There's so much to do here, and there are not much electrophysiologists in the country, so there is a lot of scope here. So at this point of time, I will leave it to Sendal to take us through this. I'll leave this slide on, Senthil, and then you'll be
Am
there.
I allowed to share some slides, or
Yeah,
I
please go on.
think you'd have to allow me to, let me see.
Yeah.
Okay.
Kitty, allow Dr. Senthil to share his slides.
Are you guys able to?
Yeah, I'm able to see it. Yeah. You
Yes,
can
sir.
go full
Okay.
you can go full screen. Yeah.
You can see him? Okay. Well, let me just put my. Well, thank you, Dr. Deep, for allowing this opportunity for me to really share my journey on my background, starting in India and then being an electrophysiologist and among this community here in the United States. I thought this will be a great talk put together by you, with all the international faculty for you guys. So my so the agenda, I'm going to talk about my journey. I think, as you mentioned, why EP is an attractive career for cardiology trainees. What's the existing path in the United States for an Indian professional coming to the United States? And then also more specifically, what opportunities we have in our program to actually have host some of the fellows and professionals in India who are interested in pursuing electrophysiology. So I graduated medical college MBBS from Chennai, Kilpauk Medical College. I finished in 2001. And at that point, I had decided pretty early that I wasn't going to pursue postgraduate in India. And I set my eyes on coming out to pursue my further postgraduate training in the United States at that point. So I had moved to Cleveland through a contact. So, and I'll talk towards the end. There are multiple ways to come into the United States. Some people choose coming as a student to enroll in one of the universities, and then they finish the USMLEs and ECFMG. I myself, I did my USMLEs in India, but then I came to the United States to pursue research just because I wanted some US experience. And there are many opportunities where there are many doctors who are willing to take on people who are, have some background in research. And I think this is a good way to get a lot of experience early on because, as you will find out later, there are two ways to come into the US to pursue EP. One is the more traditional route, which I took. So, and then there's also more other ways to do it for people who are already finished the majority of their training in India. So we'll talk about that a little bit more. Anyway, my journey, I did a year and a half of research in Cleveland Clinic, and then I applied through the system. I got what they call the electronic residency application system, ERAS, um, and got matched into what they call the internal medicine match first, matched into Creighton University Medical Center, which is in Omaha, Nebraska. I did 3 years of internal medicine training, and then I did an extra year of chief of internal medicine. And then I stayed back for cardiology fellowship, which is equivalent to the DM in India, for 3 years. And I finished that in 2010. Subsequently, I went back for electrophysiology training in Cleveland Clinic. I did that from 2010 to 2013. I stayed there for 3 years because I remained as a faculty for 1 year after fellowship, but generally the EP fellowship is 2 years. But I stayed back in Cleveland Clinic and did a year of faculty. And then I moved to Texas because of the weather primarily, and also the favorable tax structure, and also the it's a big metroplex with a lot of um, well, a lot of desi stuff to do, to be honest. So, and the travel internationally is very good. So that's how I made my move to Dallas Fort Worth after all the training, decided which is the city I want to be in. So I've been in practice for this is my 11th year now. I have been involved in the graduate medical education program. So unlike what we hear, the universities are obviously big centers of graduate medical education training, which is internal medicine cardiology. But big community hospitals with high volume practitioners also have taken over a lot of the graduate medical education training. And we are in one of them. And I was the cardiology fellowship program director from 17 to 23. And subsequently, we started the Electrophysiology Fellowship in 2023, and we have our first class running, and really excited about that. So that's my journey in a nutshell. And I want to proceed to the next. Why EP is an attractive career option for cardiology trainees. I think world over, obviously, you can never plan for what's good in 10 years from now. So everybody reacts to what's currently happening. When I started in electrophysiology, I also was very interested in procedures, but waking up at 2 a.m. for a what they call an acute ST elevation STEMI call, it's door to balloon, all that pressures. I thought I could not do it forever. And so I always say EP means elective procedures apart from electrophysiology. So I think the physicians are going to be in high demand, and it can still have a reasonable work-life balance that you can get in a cardiology career. EP procedures have started to become better, higher success rates, especially for younger patients. And I think this is where what Dr. Deep had also mentioned, having that exposure abroad with the new technology and being able to see what the success rates are and being able to take them back, I think is huge because as you will see, I have been very involved in what's happening in India because of collaboration with Dr. Deep's center and other centers. And I think the EP is at the nascent stages of taking off in India, and as it has happened in other parts of Asia, Europe before that, I think EP is in the early stages of taking off where EP was 10 to 15 years ago in the United States, and just because of the technology affordability. So high success rates, collaborative environment. EP sometimes it's not just a top of the pyramid. Sometimes you're dealing with young patients from the ER that require EP directly. Heart failure, you work with EP directly. So you actually have to work with multiple specialists within cardiology, which is also a reason a lot of the academic cardiology programs are actually run by electrophysiologists, which even I was part of. I was a cardiology fellowship program director before. So data also shows that there's more and more EP in general cardiology because 50% of admissions in the US for cardiology are either some kind of heart failure, which involves arrhythmias, or atrial fibrillation. So that's, I think, why EP is always going to be around and going to only grow. There's also rapidly advancing technology. I think these are constantly improving. As competition comes, that'll drive the prices down. There are ways to be looking at how to make this more affordable across the board. And then EP requires real-time problem solving. Not only are you just a proceduralist, but you're having to interpret a lot of electrograms. I mean, it's a separate language, and I think it can be very, the science of it is keeps you excited on top of just the procedures. This is not directly related to Indian market. I don't know the prices, but just looking at what this means and the bottom line for people who want to pursue multiple years of training, EP has continued to grow along with interventional, but kind of matches it in terms of a salary structure and how the compensation is across the board in the subspecialty. And recent reports also said compensation keeps climbing in general cardiology, but also EP and heart surgery specifically. So we're seeing this pattern even in the United States that this is continuing to grow despite being around for so long, and the pressures from structural and cardiac surgeons who do a lot more structural as well. Globally, AFib is a growing problem. AFib is the bread and butter of what we do. And it is not the case in India, I know that. But I think there will be a future where AFib will be, the patients will seek these advanced therapies that are available. As you do more and use these technology, you will come to a point where the ablation you do will evolve. When I started in practice, 3 to 4 hours have now become less than 1 hour for AFib ablation. 2 to 3 per day, you could do up to 5 to 6 per day. We don't advertise this in the US, but this is more a webinar to talk to people who are looking at interventional procedures being fast, whereas EP procedures take long. Well, that's not the case anymore. EP procedures we do quite a bit because of how fast it becomes. Success rates have also improved because of the technology. For AFib ablation, we can, multi-center trials have now shown up to 80, 90% on first-time ablations. Complication rates are lower, And also, X-ray usage is much less than what you would use in a structural heart case or an interventional case. You would never use a cine angiogram. I know Dr. Deep Center and other centers heavy into intracardiac echo. They can almost go to zero fluoro in many of these cases, but comfortably less than 5 minutes in majority of your cases. So this, I think, is why EP as a specialty will always be at the forefront of cardiology. And as trainees coming out now or maybe coming into cardiology, thinking about all this, I think the future is very bright. Technology, you might have heard of this. We have pulsed field ablation technology. Now we have three companies now that are FDA approved. So this will continue to evolve and become more affordable because the affordability and the price cost is still a talking point in the United States, even though it's supposed to be the most affordable place. These, I think, will continue to evolve in terms of when we have dual leadless spacing. We'll probably get biventricular leadless spacing in the future. Leads may not be as used anymore. Left atrial appendage occlusion continues to, multiple companies are there, and this becomes a real alternative for people who cannot take blood thinners or do not tolerate blood thinners long term. So I think there is a lot of these which are specifically um, done by electrophysiologists for the most part in the United States. I think this is very important because you want to have enough electrophysiologists so that you can continue to do these procedures because there is a balance of like, well, all these are coming out, but if the patient is not having the access to a doctor who is trained, then it becomes an issue. So I think sometimes having that skill and going to that market will get you these patients because the patients are also knowledgeable and can see who's specifically trained to do this on these on their loved ones or on themselves. So that's, I think, is important. Just a slide, not to belabor EP growth. It continues to grow as a general field. So this will mean that electrophysiologists will be a part of this growth as well because you'll have to match this. And Asia Pacific is going to be the fastest growing market. North America is the largest market share, but the market growth rate is going to be in the Asia Pacific. So yes, India still has time to things to go before it has to catch up. But if you're thinking of a career now in your early stages, you could be positioning yourself when it really is taking off at the highest level, and opens up opportunities for you as it continues to grow in other parts of Asia as well. Even in the United States, the current state, we have advocacy going on. Less than 1% of patients who need ablation have access to it, according to data. There are less than 2,500 electrophysiologists to treat over 6.5 million patients. Now, I know the numbers in India will be even more staggering, but even in the United States, that's an underserved. There are not enough electrophysiologists in the inner city and rural America. I mean, there are a lot of opportunities, and this is relevant because of certain changes in the healthcare policies and stuff that are being foreseen in the United States. They're not officially on law yet, but there's a lot of pressure, and I will show you what they are in part of the presentation that you guys can reference. This is important because, yes, there are many EPs in Dallas, Fort Worth, but if I go 1 hour, 2 hours from here, that's where interventional cardiologists may have to be doing it, but there is nobody doing it. So then patients don't have that access, even in the United States. Total dollars spent is still minuscule. So we don't expect, other than the usual Medicare cut that happens across board for all physicians, we don't expect major reductions. And currently across the United States, there are 156 electrophysiology fellows. This is the most, probably the largest, but it is still small numbers compared to about 8,000 cardiologists, or I think somewhere in the range of thousands that are being trained. So EP is still underserved and undertrained. And because of structural, there is also that pressure in EP. But I think if you have some passion to want to have to do procedures and be academic and be involved in research, cutting edge technology, I think you will find a lot of rewards in EP. And as the growth of EP market happens, you will still have it. Now, specific to the United States, some lingo that you guys need to be aware of because this depends on where you are in your training. I mean, this might be a post-MBBS student who's thinking of electrophysiology long term. But there are EP training. There is ACGME that determines program requirements for eligibility for fellowship training. So I'm very aware of it, but just to let you guys know, ABIM is that certifies for board certification after completion of training. And then there are medical boards that have to license you to be able to practice medicine. So these three are kind of the things. So when you qualify for one, you may not qualify for the other. So these are, but there are nuances in each. And I think there are opportunities when this comes to that. So broadly speaking, we have an EP fellowship. To apply for electrophysiology fellowship, the usual pathway is you finish your MD or MBBS from a school, you finish your USMLEs, ECFMG certificate, then you apply for internal medicine residency, and then you do 2 to 3 years cardiology fellowship, then you apply for EP fellowship. That's the usual pathway. That's how I did it. It's still the most efficient if you in your career that you want to be in EP. It's the opportunity to go back to practice if needed. There are many doctors from here who have gone back. Um, I just want to make sure the recording was okay. So, and then the other thing is for international fellows. So these are doctors who are already done their internal medicine in India, cardiology, maybe even some EP, but not got the full, want to pursue more advanced EP fellowship. Well, there is an ACGME official pathway. You have to still take your USMLEs, get your ECFMD certificate. You have to have completed this residency in the core specialty outside the United States that is not ACGME, so from a program in India that is qualified and accredited. And the second is the most important. You have to be of exceptional quality. And this is subjective, but then there are some objective things that are told in the ACGME document. One, your participation in additional clinical research training. This is where I think we were talking with Deep that if you spend a year, you do cardiology, that's considered core, but if you spend a year in additional clinical research training in the specialty or subspecialty in a center like Dr. Deep Center or any other center where you spend, then that would be considered that you now can pursue an ACGME accredited fellowship, and you have demonstrated scholarship publications in the electrophysiology. So this would make yourself very competitive to be able to get into our fellowship and honestly to any EP fellowship in the country. And demonstrated leadership, that's verbatim from that. If you apply for so if you have finished this and you apply, you finish your ECFMG, you technically can still interview for these spots. Now, big centers always take in an international fellow. But what that means is it doesn't mean that you can stay back and do the boards. That is a totally different way to do it. So there are on ACGME as well. We also offer this. I'll talk about it. You can come in because you're exceptionally qualified to perform a year of clinical, what they call cardiac clinical research. What this allows you is exposure to the US system. You are specifically doing it in the area that you are interested in. If you decide to go back, you will still do some clinical activity that allows you to have some experience. But then you have just decided to come here, get it done, and you want to go back to India to use that knowledge and experience. So then you don't need to go through a full ACGME process. You can avail non-ACGME. Not many centers have this. We are a center which has it. There are other programs that have it too, but you'll have to seek them out. But the advantage with this is it's probably an easier way for you to just concentrate on what to do and then take that experience back and then get a lot of research so that you can stay relevant in the world. You can also stay back as faculty with this in the institution because you've stayed and done some work with them. So these are ways to come to the US for training, especially if you've already done your cardiology and just looking to do EP. These are reasons I believe it's going to become more not only attractive, but a little bit easier than it used to be able to come into the US to do electrophysiology in the future when you've already done all the training in India and you now want more advanced training. Because there is an ABIM pilot. Remember, I talked about ACGME. Only when you can finish an ACGME, you can sit for boards, generally speaking, from here. But if you do it as international, you generally are not allowed to sit for ABIM boards directly. You'll have to go back. The IM program director has to petition and get you a reduced amount of training in internal medicine to be able to sit for internal medicine, then cardiology, then EP. So if you see here, the ACGME as an exceptionally qualified candidate, you did an ACGME accredited fellowship, but you're not eligible for certification. The pilot program proposal, which is not active, but it is going to be probably soon because they're in the survey period to figure out how to do it. And if this is meaning that you don't need to do a full residency and fellowship again. You can sit for the ACGME, you can sit for the IM if you're eligible based on the fact that you've done an ACGME fellowship training and you're an exceptional candidate based on what you've done before. Right now, it's on a case-by-case basis, but the pilot, I think we are going to participate, hopefully, when it becomes active, allows you to probably sit for the boards without having to. What this allows is not only have you finished the EP fellowship, you are now going potential have an opportunity to become board certified. There are now other opportunities that are probably going to come out in the future. One of the things I wanted to point out here is these are states which are now becoming underserved in physicians and are saying we are going to potentially, there's legislation, for example, in the dark green, Tennessee and Illinois, where it's passed by, it has not fully ratified, the board hasn't accepted it, but it's passed by legislation that an international physician, well qualified in an area of need, specialty in a rural place, can get a license directly without having to do all the residency and fellowship. So this is not a common, but it's just happening in the last few years. And if you see across the board, there are other various stages of passing legislation. So I think if you Google, you can find this information. But this is the stage. So three things as I talk about. The ACGME is to get into a fellowship, and you can look at qualifications that you need. The ABIM is to get board certified, where we think there are a couple of pathways to do it. And then the licensing, right now, you have to have both the board certification and the fellowship to be able to get licensing. Now, the licensing is also being cut down, made it easier in some of these states without having to do the other two. So I'm just telling you the general, give you an overview of how the US works. But to go back to it, specifically what fellowship opportunities we have the clinical cardiac EP fellowship, ACGMA accredited, that we have two spots, one per year we typically take because it's a 2-year fellowship. The traditional is people do internal medicine and cardiology, then apply locally. But if you're an exceptionally qualified international graduate and you have done some basic training in EP there, potentially we can look at that candidate as well. And this is what we want to work with some centers in India. There is also the cardiac arrhythmia research fellowship, which is non-ACGME, which we also can, there where they can have 20% clinical, 20 to 30% clinical of their focus, but spend a lot of time doing research as well and do it. But that's for people who have not done any EP training, but want to come to the US to get an exposure to EP and potentially with that experience stay back to do more additional ACGME years to get a full, well-rounded experience and then decide on what the future opportunities are. Our group volume, we have 27 electrophysiologists across Texas. You'll work with 5 or 6 on a regular basis, but some of the leading names there, you get to have opportunities to do electives with them as well, if you have certain particular interests. There's access to about 4 to 5 EP labs and 2 hybrid OR labs. We do about exposure for the fellows, about 500 to 600 AFib ablations per year, 250 to 300 left atrial appendage occlusions, a smattering of SVT, VT. We do a whole gamut of epicardial procedures, leadless pacemakers, laser lead extraction. So you'll get the full well-rounded experience, either as an ACME fellow or a cardiac arrhythmia research fellow that we usually open it up more for international people at that point because the ACME is really for local graduates or
Hi
local
guys, how are you?
cardiology. So with that, I'd like to thank you guys. Sorry if I overrun my time. I didn't realize I had that many slides, but hopefully that was a good overview of how the US processes and a little bit of my journey. I have my contact information here, and I'm on LinkedIn and Twitter if you guys are on it to communicate as well. Thank you.
Thank you. Thank you, Dr. Senthil. That was wonderful. It was so very important. It's invaluable information here for people who are trying to go to the US from the country. And sure, you can, I will share the link with you of the recorded presentation. You can share the link to the people who are interested. You have enumerated in detail. Love the way that you mentioned that you reduce the cath lab time, the way the procedures have evolved in electrophysiology is reducing the cath lab time. You're
Mm.
able to do 5 to 6 AFibs in a day with the pulse field ablations and all those things. And then to all the people who are listening, again, research was the way, academics is the route that you chose to enter into the US. That is very important in this field. The balance that you mentioned, the work balance, better than the structural interventions, that was very well taken. And it was a good way to compare structural interventions with us. Then, yes, the work balance is better in electrophysiology. Absolutely no radiation exposure, I would say, nowadays. And then number of electrophysiologists, again, like the way you put it, even US is considered to have the highest number of electrophysiologists. Still, you say the country is underserved, and you still don't have much of electrophysiologists. And imagine a country like India, trillion population, we have barely 100 to 150 electrophysiologists, and barely 50 electrophysiologists to do almost all of the 3D mapping and all those stuff. It's a big gap that we are facing, and that's exactly this webinar is meant to encourage the younger people to take up this field and hopefully increase the number of people take up this field of electrophysiology.